Hello, friends. Welcome to this image-based discussion on anesthesia. Right. We'll be discussing a few images. Good evening. Good evening. How's preparation going on, friends? Before starting the session, let me just clear this thing that if someone asks me that image-based session is enough enough, sir, for preparing for FMGE or NEET PG, then the answer is no. Because you have to combine the image-based session with LRR at least. I'm not saying that it will replace the whole lectures of anesthesia, but at least you have to have that basis, okay? Now, guys, starting with the session, right? We'll start the session with the first question. A patient comes with a parotid gland swelling. While doing the PAC, we see this mouth opening. How would you proceed to secure his airway for general anesthesia? This patient came to me for a PAC. He was having this much mouth opening. Now, guys, first of all, tell me, is it a case of easy or difficult airway? Come on, be fast. Is it a case of difficult or easy airway? By looking at the mouth opening, we can easily tell. Very good. It's a case of difficult airway. Now, how did you say that it's a case of difficult airway? Why? Because, sir, two things are easily visible to us. When he's opening his mouth, his inter-incisor distance appears very low. Normal inter-incisor distance is between 4 to 5 centimeters, but it is very low. So it is a difficult airway. Apart from that, while he's opening his mouth, right, are you able to see any structure? If you tell the patient to lift while opening his mouth, you might be able to see only the hard palate. So if you are only able to see the hard palate, he is having a Mallampati classification of 4. That means he's having a difficult airway. Okay? Now, guys, before proceeding towards the answer, how would you proceed to secure this airway? First, we need to understand, guys, for airway assessment, what are the things that we need to do? For airway assessment, we do two things, guys. When a patient comes for PAC, in the airway assessment, we tell the patient to open his mouth and lift his chin. While he's opening mouth, you look for the inter-incisor distance, which is normally 4 to 5 centimeters, and you look for the structures which are easily visible. That structural classification is called as Mallampati classification, guys. It's called as Mallampati classification. So now you can see over here, this is Mallampati classification. In Mallampati classification, there are 4 grades, grade 1, 2, 3, and 4. There is one more grade called as grade 0. When do you call it as grade 1? When a patient opens his mouth and you see all the structures. Yani you see hard palate, soft palate, uvula, tonsillar pillars, everything. Yani basically in Mallampati class 1, if you see, sorry. Mallampati class 1 means if you see push, P-U-S-H, P stands for the tonsillar pillars, U stands for whole of uvula, S stands for soft palate, H stands for hard palate. All structures clearly visible class 1. Okay? Then class 2. Class 2 means what? You just remove the P from, remove the P alphabet. U, S, H. It is class 2. Yani ke you will see what? Uvula, soft palate and hard palate. But whole of the uvula is not seen. Partial uvula is seen. Soft palate is seen and hard palate is seen. And plus, you might also be able to see, partially you will also be able to see the tonsillar pillars. Partially tonsillar pillars visible. That is Mallampati class 2. Okay? We have already discussed. We are now discussing just the images of it. Okay? Class 3 means what, guys? We need to remember SH. Class 1 was PUSH, 2 was USH, then it is SH. S stands for what? When a patient is opening his mouth, you are able to see the soft palate, you are able to see the hard palate. Okay? And base of uvula is also visible. But soft and hard palate are the main structures that are visible. And class 4 means what? Only H is available or H is visible. That means what? Only hard palate is visible. That is class 4. So in our case, guys, this patient was having Mallampati class 4. As he opened his mouth, I was only able to see the hard palate. Okay? So that's regarding the Mallampati classification. Now, guys, now just look over here. Right. This is what, guys. What is this? A patient comes to your OP, you are doing a PAC, he opens his mouth. You are able to see the hard palate, you are able to see the soft palate, you are able to see the whole of uvula, you are able to see the tonsillar pillars, plus you are able to see the tip of epiglottis. Tip of epiglottis. Yani कि basically you need to understand with PUSH, यानी कि with all fold structures of class 1, if you are able to see the tip of epiglottis, then it is class 0. This indicates the patient is having a very easy airway. Okay. Now, guys, look over here. And second thing that you do in the airway assessment is you tell the patient to lift his chin. While he is lifting his chin, just look over here. You look for two distances. One is the distance between the mentum and the thyroid cartilage, which is called as thyromental distance, which should be normally how much, guys? It should be more than 6.5 centimeters. Other distance is between the mentum and the sternal notch, which is more than 12.5 centimeters, or basically the double of thyromental distance. With this, we can come to know this patient is having an easy or this patient is having a difficult airway. Now, guys, remember, right? Now, class 0, just now we have discussed. Now, okay? So look over here. Now, our question was, how do you proceed to secure his airway? You remember, this was our patient. How will you secure his airway? Now, remember, this patient was having parotid gland swelling. Any answer, guys? How will you secure the airway? Any answer? Come on. Just type down your answer. How will you secure this airway? Then we can discuss a few things about it. Okay, someone is telling me LMA. Okay, LMA can be done, but again, parotid gland swelling and all, it's better that you go for a definitive airway. LMA is not a definitive airway. Someone is telling tracheostomy. Okay. Remember, the best over here would be tracheostomy. I totally agree with you. Why? Because if he's not having mouth open, tracheostomy could be done. But guys, look over here. Tracheostomy comes with complication. Patient is coming with parotid gland swelling. The surgery is not itself a big thing, but doing tracheostomy and securing the airway would be what? It comes with complications. Immediate complications of tracheostomy, you will see what? Subcutaneous emphysema you can see, or delayed complication of tracheostomy means you might see some fistulas developing, tracheoesophageal fistula, tracheal stenosis developing. So you don't want this patient to complicate much. Better than tracheostomy, are you having any other options? Can you intubate the patient orally, guys? That's my question. Definitive is always tracheostomy, but for this patient who's having parotid gland swelling, can you go for orotracheal intubation? Remember, tracheostomy is the definitive management. When a patient is having a restricted mouth opening and requires general anesthesia, tracheostomy is definitive management, but not the best one, guys. Okay? In tracheostomy, remember, this is the tracheostomy tube that we normally use. Okay, and this equipments are basically the difficult airway equipment trolley, guys, where you see the laryngoscope, you see lignocaine gel, you see the Magel's forceps, you see the laryngeal mask airway, you see Goodell's airway and all. Okay, right. So the question is, can you go for orotracheal intubation? Yes, orotracheal intubation can be done. Orotracheal intubation can be done. Now, guys, look over here. In orotracheal intubation, how will you go for orotracheal intubation? First of all, remember this patient came for me for a PAC. It's an elective surgery. When I know that this patient is having a difficult airway, I have anticipated. When you have an anticipated difficult airway, you will prepare yourself with equipments that are used to handle that case. What are the equipments? Over here, I'll show a video. How did I intubate this patient? Just look over here, guys. How did I intubate this patient? I'll basically go for a video laryngoscope. In video laryngoscope, there are many varieties. I will go for a CMAC. CMAC is nothing but on the laryngoscope tip, there will be a camera. Okay. As I introduce the laryngoscope, just look over here. This patient, what I did, just look over here. I introduced the blade and I saw the epiglottis. Now just look over here. I tried to lift the epiglottis. When I was trying to lift the epiglottis, am I able to see the vocal cords, guys? Normally, when you lift the epiglottis, you should see the vocal cords. but I was not able to see the vocal cords. But at the same time, I was able to see a small cartilage, that is cuneiform cartilage. That is the opening of vocal cords. So what I did, I took a small stick called as bougie and put that bougie blindly following just beneath the epiglottis will be the vocal cords. I had slided the bougie inside the vocal cords. Okay, I did not see the vocal cords, but I know that cuneiform cartilage is the opening of the vocal cords. Then over the bougie, I have slided the endotracheal tube. Endotracheal tube. Okay. So remember, guys, this is a CMAC. So we are discussing about what we can intubate the patient. Remember, if it is an anticipated airway, you will be preparing yourself with a video laryngoscope and difficult airway equipments already you are ready. Okay. So what is the equipment that I used for intubating? I used a CMAC, and then once vocal cords were not visible, blindly have introduced a stick which is called as bougie. As you can see over here, this stick is called as bougie. Once you insert the bougie, you will feel as the bougie is going inside, you will feel some tracheal rings. You will feel the tracheal rings thing on the bougie, and then you can slide the endotracheal tube. Okay, so that's regarding what, guys, this is a bougie. Sometimes, guys, remember, if bougie is not there, right, what you can do is you can take a small device, a small stick, one more stick is there, which is called a stillet. What is stillet used for, guys? Remember, endotracheal tube is a bit curved, but not that much curved that it can directly enter the vocal cords. We can take the stillet, we can put the stillet inside the endotracheal tube, we can make the we can make the stillet position in that, so that in that angle, so that it can easily enter the vocal cords. So remember, in difficult airway, what are the equipments that we are discussing? The one that I have showed you in the video was bougie. Next is stillet. Stillet you put inside the endotracheal tube so that the endotracheal tube takes the shape of the stillet and it makes an angle which is easy to intubate. Okay. Now, guys, next. Now, imagine, guys, that was for anticipated. Remember, guys, anticipated yani कि you know that the patient is having difficult airway. Now, guys, imagine a patient comes to you for a PAC and he is having a Mallampati classification 2 airway. Yani कि he is having a easy airway. And at the time of intubation, you are not able to find the vocal cords. Again, guys, this thing can also happen. Okay, Mallampatti classification doesn't mean that sure shot he will be having easy airway. 90% of the time it will be easy, but sometimes it can be a difficult airway. If at all, patient comes with Mallampatti classification and on the table you see that the patient is having a difficult airway. Yani ke, were you anticipating? No. Unanticipated difficult airway, how will you manage? For that, guys, just look over here. For unanticipated difficult airway, we go for the DAS guidelines, guys. In DAS guidelines, they are plan A, B, C, D. What is plan A? You will give your best attempt. Best attempt means what? Best attempt means proper positioning of the patient, proper laryngoscopy has to be done. Okay? And you have to give your best attempt to find the vocal cords. Okay? Plan A is you need to find for the vocal cords and you try to intubate. If plan A fails, okay, then you need to go for plan B. And okay, if plan A fails, you will see that the patient's saturation is falling. Then what you will do, you need to go for plan B. Plan B is remove the remove the laryngoscope and all, and now put a temporary airway device or a non-definitive airway device, which is called as laryngeal mask airway. Okay? So plan B is putting a laryngeal mask airway. But after, imagine, guys, after putting a laryngeal mask airway, 90% of the time, usually the saturation increases. But in some patients, what will happen? The laryngeal mask airway is also not sufficient. The patient saturation is still falling. In those scenario, what you need to do? You need to go for plan C. Come on, guys. What is plan C? Plan C is, yani कि basically now you are not able to ventilate through the, you're not able to put the tube, you're not able to put the LMA. Plan C is you need to call your assistant and you need to go for bag mask ventilation with 2% technique. 2% technique means what? One person will be holding the mask, other person will be holding the bag, and they will be ventilating. Yani कि it is a 2% technique of ventilation. 2% technique of ventilation. Okay. Now, if this also fails, then it is a nightmare, guys. It's a nightmare for any anesthetist. Now you are in a situation called as CI, cannot intubate, cannot ventilate. CICV, cannot intubate, cannot ventilate. In that scenario, what you need to do? Last option plan D is what? Emergency cricothyroidotomy. Yani with the help of laryngeal handshake, you will find the cricothyroid membrane and you give a stab incision and you basically introduce the bougie and introduce a tube through the opening. So that is emergency cricothyroidotomy. That is plan D. So that is the difficult airway guidelines, guys. Okay, that's the difficult airway guidelines. Now, guys, for doing intubation, what are the things required? What is the positioning required? Again, it's in the picture. What is the instruments required? What tube is required? If you fail intubation, what is required? We'll discuss now. Okay, so look over here, guys. What is the positioning required for intubation? For a normal intubation, for intubating a normal person who is healthy, not obese, you require the patient to be in a sniffing morning air posture. Sniffing morning air posture means what? In sniffing morning air posture, there is flexion at the cervical spine. Again, an important thing, flexion at the cervical spine and extension at the atlanto-occipital joint. Atlanto-occipital joint. Okay? Rose position is different, guys. Rose position means you are putting the pillow beneath the shoulder blades. That is basically for this thing, tonsillectomies and all. Okay. So sniffing morning air posture is this, right? Next is what, guys? Next is rammed position. Remember, guys, sniffing morning air posture is done for normal patients who are healthy. Healthy means who are not obese. In patients who are obese, remember, whether you go for sniffing or rammed position, the main aim is what? While intubating, I should see the vocal cords. The oral, pharyngeal and the laryngeal axis should be in a one line so that you can see the vocal cords properly. Okay? In obese patient, you cannot go for sniffing morning air posture. In obese patient, if you want to have all three axes in a same direction, then you have to go for rammed up position. Rammed up position that you go for obese patient. Usually for tonsillectomies, you go for rose position, guys. Okay. Now look over here. What are the instruments required for intubation? So first thing that is required after positioning, first thing that is required is laryngoscopy, guys. Now there are different type of laryngoscope. This laryngoscope is commonly used. This comes in two blades, guys. This comes in two blades. Blade A is called as Miller's laryngoscope, which is commonly used in pediatric age group. This is the straight blade, Miller's laryngoscope. Why this is used in pediatric? Why? Because they are having a larger epiglottis which can be easily lifted. This curved blade laryngoscope is called as Macintosh laryngoscope, commonly used in adults, guys. Okay, but after this discovery, there were many laryngoscopes came in order to ease the pressure of intubation. Okay, so after this, it came the McCoy laryngoscope. McCoy laryngoscope. McCoy laryngoscopes comes with a handle, guys. With a handle means it comes with a small slender handle. If you push this handle, it will try to pull up the tongue. Okay, so that you can see the vocal cords properly. McCoy. Now this is McCoy. Now this is a type of video laryngoscope which is called as McGrath. Okay, in video laryngoscope, guys, there are many video laryngoscope. The one that we used was CMAC. There is McGrath. There is many video laryngoscopes. Okay, now just look over here. Once you have introduced the laryngoscope in the patient's mouth, you will lift the tongue. While you lift the tongue, now the laryngeal aperture is visible to you. Based on the visibility of laryngeal aperture, you will give a classification which is called as Cormack-Lehan grading. Cormack-Lehan grading is done at the time of intubation, not in the PAC. In PAC, only Mallampatti. So remember, guys, in Cormack-Lehan, there are 4 grades. First grade is what? If you see the full laryngeal aperture, if you see the full laryngeal aperture, it is called as grade 1. Grade 2 is what, guys? When do you call as Cormack-Lehan grade 2? If only posterior laryngeal aperture is seen or posterior wall of laryngeal aperture is seen. It is grade 2. In grade 3, only epiglottis seen. And grade 4 Cormac-Lehman means what? Epiglottis is also not seen. No epiglottis. Now, guys, look over here. In our case, what was the Cormac-Lehman? Come on. In our case, what was the Cormac-Lehman? Our case means you have seen now with CMAC, I was trying to intubate the patient. CMAC I have introduced and the laryngoscope I have introduced. While lifting the epiglottis, I was not able to see the vocal cords. Very good, very good. Our case, bhai, remember if epiglottis is also not visible, that is grade 4. But in our case, we were seeing epiglottis, but not the vocal cords. I was just able to see the cuneiform cartilage, which is seen at the opening of the vocal cord. So it is grade 3. In our case, what is the Cormac-Lehman grading? Very good. It is grade 3. Okay. So anyways, this is regarding Cormac-Lehman grading. Now look over here, guys. Now, if you see the vocal cords, what is the next thing that we need to do? Introduce the endotracheal tubes. Now, guys, there are two kinds of endotracheal tubes which are available. Now, what are the two types of endotracheal tubes available? One is called as red rubber tube, which we are not at all using. Red rubber tubes, why we are not using? There is one reason. Why? Because it comes with a very high pressure and low volume. Due to this pressure, patient is having tracheal mucosal injury. Tracheal mucosal injury. Hence, we are not using red rubber tubes. Now we are using the tubes which are made up of PVC. Now, PVC tubes are, these are low pressure, high volume cuff. Yani ke, how much of, like if you infuse good amount of air also, the pressure wouldn't be that much. Yani ke low pressure, high volume cuff. Now, in this also, there are two types, guys. In this PVC tube also, there are two types. One is called as the cuffed tube and other is called as a uncuffed tube. Red rubber tube, high pressure, low volume. Yes, right. So, PVC, there are two kinds of tube. One is the cuffed, other is the uncuffed, guys. Now look over here. Uncuffed tube were commonly used in pediatrics, but nowadays we are not using uncuffed tube in pediatrics. We are using micro size cuffed tube in pediatrics. Okay. Now, in this tube, the most important part of the tube that we need to remember is the one more opening. Remember, one opening of the tube is where the person is placing his finger over here, and one more opening is given on the lateral side of the main opening. What is that opening called as? This opening is called as Murphy's eye. What is the role of Murphy's eye? The Murphy's eye role is what? If the main opening gets blocked by secretions, the patient can be ventilated with the Murphy's eye. Okay, that's regarding what, guys? That's regarding the endotracheal tube. Okay, now there is one more thing that we need to remember. Micro-sized cuff tube in adults and micro-sized cuff tube in pediatric cases nowadays that we are using. Now, what is the narrowest portion while passing the endotracheal tube in adults? What is the narrowest portion that you see? Remember, guys, the narrowest portion of the adult airway is what? It is the glottic opening. It is the glottic opening. Whereas in the pediatric airway, it is the subglottis. It is the subglottis. Sir, in Murphy's eye, no. Murphy's eye was not present in the red rubber tube. Okay. Now, guys, remember, they will be asking you what is the diameter, what is the size of endotracheal tube. Size of endotracheal tube usually that we use in adults, females is 7.5, males it is 8 and 8.5. What does the size indicate? The size is nothing but the internal diameter of the endotracheal tube. Just look over here. What is the internal diameter? I am holding the endotracheal tube, and this is the internal diameter of the endotracheal tube. Okay, internal diameter. And this internal diameter determines the resistance. Internal diameter determines the resistance. Okay. Now, guys, what are the other forms of endotracheal tube? Other types of endotracheal tube that are available are the endotracheal tube which can easily bend. That is called as the reinforced tube, or it is also called as the armored tube or the flexometallic tube. Armored or flexometallic tube. Now, when this tube is used, when a patient is posted for any surgery under general anesthesia in a prone position. In prone position, if you use a normal endotracheal tube, it will kink, guys. But if you use this kind of tube, it won't kink. Why? Because it's a metal. There is a metallic component that prevents kinking of the tube. So flexometallic or armored tube is used for prone position surgeries. Now, next form of endotracheal tube is called as raised tube. What is raised? Ring Adair Elvin tube. Now there are two types of ring Adair Elvin tube. One tube opening is facing towards the legs. After intubating, it is the opening is facing towards the legs, that is south facing. Other is facing towards the head, that is called as north facing. Raised tube is used for what surgeries? Now remember, ray tube is nothing but a nasotracheal tube. When do you go for a nasotracheal tube? यानी कि nasotracheal means you are putting through the nose into the vocal cords. When do you go for it? When a patient is posted for some oral pathology. It could be some wisdom tooth removal. It could be some oral surgery, oral rehabilitation. It could be oral cancer surgery. Okay. So nasotracheal tube is raised tube, right? Next, what is the tube that you see over here? This is called as DLT. DLT, right? DLT is nothing but double lumen tube. Now, when do you use this double lumen tube, guys? What is the usage of double lumen tube? Double lumen tube is a very long tube. It is used for surgeries requiring one lung ventilation. Surgeries requiring one lung ventilation. Now, guys, which surgeries require one lung ventilation? Basically the lung cancer or any surgery or like lung abscess that has to be drained. You have to have a long tube that will just ventilate one lung, whereas sparing the other lung. Once you place this tube, how will you confirm the exact placement of it? By fiber optic bronchoscope. By fiber optic bronchoscope, you will confirm the placement of DLT, double lumen tube. Okay. Now, guys, look over here. Whereas normal endotracheal tube placement, if we are leaving the double lumen tube, if you place a normal endotracheal tube, how will you confirm that it is in the trachea? The best way to confirm the best way to confirm the endotracheal intubation is what? The best test is, it is capnograph. Very, very important. Capnograph. यानी कि basically after doing intubation, just connect the capnograph port to your endotracheal tube and you will see a waveform coming like this. If a waveform is coming like this, that means you are in the trachea. Why? Because as you are in the trachea, you will be exhaling carbon dioxide and you will see this waveform. The exhaled carbon dioxide is measured in a form called as capnogram or capnograph. Now there are four phases of this capnograph, guys. Phase 1. What is the phase 1 called as? It is called as inspiratory baseline. Inspiratory baseline. Then there is phase 2. Phase 2 is called as what, guys? It is called as expiratory upstroke. Expiratory upstroke. यानी कि patient has begun to expire the carbon dioxide. Phase 3 is called as the alveolar plateau. Alveolar plateau, and phase 4 is called as inspiratory downstroke. Now, guys, in between the phase 2 and phase 3, there is an angle formed which is called as alpha, and phase 3 and phase 0, there is one angle formed called as beta. And remember, guys, this angle called as beta, this is very important. Why? Because capnograph is measured, or it is the best measured at this point. Capnograph is best measured at beta angle. Okay. Now this is the capnograph. Now we'll just brush up through the capnographs, guys. Different kinds of capnographs. Just look over here. I have already drawn the capnograph. This is the first capnograph that you see. Remember, normal capnograph I have already shown you. When you see this kind of capnograph, is it normal or abnormal? It is abnormal. Abnormal means what, guys? What is happening over here? Just look over here. What is happening over here? It looks like a shark fin. It looks like a shark fin. Shark fin capnograph is an indication of what? It's an indication of bronchospasm. Is an indication of bronchospasm. bronchospasm. Okay, shark fin capnography is seen in bronchospasm. Okay. Now, the second capnograph, guys, just look over here. Second capnograph is what? Yani ke patient was like during the capnography, you are seeing some waves coming like this. Is it normal, abnormal? It is abnormal. What is abnormal, guys, over here? This small notch is coming. What is that small notch called as? This notch is called as Curare notch. That indicates that the spontaneous circulation has returned. It indicates return of spontaneous ventilation, not circulation, spontaneous ventilation. And when there is return of spontaneous ventilation, what do you need to do? Basically, before this, the capnograph was normal. And now suddenly when the patient is spontaneously breathing, you will see this. That indicates patient has been out of the muscle relaxant effect, and now you have to give muscle relaxant to the patient. Muscle relaxant has to be given. Okay. Next, guys, the third capnograph that you see over here is what? It is the step ladder increase. Slowly, the pattern of capnograph is increasing. This you will see when the patient is suffering with malignant hyperthermia. Malignant hyperthermia, you will see this capnograph. Okay. Next is the fourth capnograph. Guys, when do you see this capnograph? You see this capnograph. Remember, first of all, one small thing that you need to remember is normal capnograph reading is between 35 to 45 mm of Hg. Yani ke whenever you are intubating the patient, capnograph should reach a certain height. The ETCO2 should reach a certain height. The normal height is this, the dotted line over here. But in this fourth capnograph, what do you see? Is the ETCO2 reaching the certain height? No. What is happening? It is being exhausting. So over here, what is happening, guys? If I increase the respiratory rate, what will happen to the carbon dioxide? Carbon dioxide gets washed off and you will see this capnograph. So this is seen in hyperventilation. When you hyperventilate the patient, carbon dioxide is washed off and you will see this capnograph. Okay. Now, fifth capnograph. When do you see this capnograph? This capnograph means what? Now, this is above the normal ETCO2 value. Okay. Now, look over here. When does it happen? This happens when you are hypoventilating. Hypoventilating means what? Normal respiratory rate 12 to 18. But if you are setting a respiratory rate of 8, what will happen? That respiratory rate is not enough for the patient, and slowly the carbon dioxide gets accumulated much. So in case of hypoventilation, you will see a capnograph like this. And last capnograph, guys, what do you see over here? The last one. Capnograph, is it starting from the baseline? No, it is above the baseline. Capnograph rising above the baseline means what? Carbon dioxide is above the baseline. It means the one thing in the machine that absorbs carbon dioxide is not working properly. In cases of, remember guys, who absorbs carbon dioxide in the machine? It is a soda lime. If the soda lime gets exhausted, you will see this capnograph. In soda lime exhaustion, you will see this capnograph. Okay. Okay, can you explain the fourth? Remember, guys, in fourth case, I told you if I increase the respiratory rate, carbon dioxide is washed off and you will see capnograph value being reduced. Okay. Now that was regarding capnography. Now, guys, look over here. What is this tube? Just a second. Just a second, guys. Now, I need to charge this thing up. Just a second. Sorry, guys, for the delay. Right. But sir, how in the patient carbon dioxide? Remember, when you increase the respiratory rate, basically the carbon dioxide is washed off only, na? In cases of COPD, if the patient is having carbon dioxide getting accumulated, normally what we do, we increase the respiratory rate so that his carbon dioxide gets washed off. Okay. Now, over here, guys, what is this tube that is being given over here? It is the combi tube. It is the combi tube. Now, don't confuse yourself between the combi tube as well as the other tube. What was the other tube that I have already shown you? Other tube is double lumen tube. Combi tube is different, double lumen tube is different. Now look over here, guys. Why am I telling combi tube is different is, remember, if at all you don't know how to intubate a person, if you have this tube available, you can easily just put it blindly. No laryngoscopy is required. Why am I telling it? Normally this is used by paramedics and all. They've introduced this tube. What can happen, guys? Either of the thing can happen. Either the tube might go into the trachea. If the tube is going into the trachea, then you have to just confirm whether it is in trachea or not by auscultation. If you are seeing the air sounds in the chest, that it means you are in the trachea, and you can ventilate the patient through this port. But guys, imagine as you are introducing blindly, there are chances that a tube might go into the esophagus. So what can happen if at all your tube has not gone into the trachea? What can happen, guys? The tube might go into the esophagus. In case the combi tube has gone into the esophagus also, just look over here. You are having this small ports over here, yes or no, right? In case it has gone into the esophagus, just just you have to block this port so that the air, so that the contents of the esophagus does not regurgitate out, and you can ventilate the patient through this port. Yani कि basically you are blocking the esophagus and you are ventilating the patient through this port. That is called as combi tube. Okay. Combi tube, it is used in emergencies. Now, guys, imagine if you have failed to intubate a person. If you have failed to intubate a person, then what you require, guys? If you have failed to intubate a person, you require a device which is called as LMA. Okay. Combi tube, is it not clear? Guys, remember, just look over here. Combi tube. Combi tube means you have to introduce the tube blindly into the patient's mouth. Either of the thing can happen. Either it can go into the trachea or the esophagus. If it is going into the trachea, ventilate through the tracheal port. If it is going into the esophagus, block the esophagus by just, you can see the scuff, right? You have to inflate the scuff and block the esophagus. And then through the other, remember, this openings are there, no? Right? Through the other port, you can ventilate the patient. That is the combi tube. Is it clear? Chalo, theek hai. Right, next. Next. Guys, is it clear? Please give a thumbs up. How you can block means you are just blocking one end. There are two openings in the combi tube, right? If you are in the trachea, you will know, you can ventilate through the other, the opening that is for the trachea. Right. Just look over here. If at all the intubation fails, guys, next you have to go for a non-definitive airway device, which is called as LMA. In the LMA, there is two generations or three generations of LMA. Just look over here, guys. Any laryngeal mask airway which is having one lumen or one opening is a first generation LMA. And what is this first generation LMA? Examples of first generation LMA are classical LMA. It is a first generation. This LMA is a classical LMA which was introduced first. Then there is a flexible LMA or flexometallic LMA. Okay, it's also having one opening. Then there is a Cobra LMA. Then there is Ambu Aura 40 LMA. Okay, all these come under class 1 or first generation LMA, right? So when the tube goes into the esophagus, how the opening ventilate the trachea combi tube. Remember, when the tube is in the esophagus, you are blocking the lumen of the esophagus. You are using the combi tube is having two ports are there, na? You will be ventilating through the tracheal port, and the tracheal port openings are much above the vocal cords and all. I have shown you. Through that four openings, you can easily ventilate through these four openings. These four openings you can easily ventilate. Okay. Chalo, chalo, chalo. Right. This is the first generation. When do you call it a second generation LMA? When you add extra one more lumen to the LMA, it becomes second generation. That second generation LMA examples are what, guys? Now, extra lumen, why did you add first of all? The reason for adding an extra lumen is basically to prevent the risk of aspiration. As it is a supraglottic airway, fits in the supraglottic area, will ventilate both the trachea as well as some gases will go into the esophagus. Just to prevent that gastric aspiration, you go for second generation. In second generation, you are having examples of LMA, Pro Seal, you are having LMA Supreme that is made up of polyvinyl chloride. Okay. Next is iGel. iGel is an LMA that does not have any cuff. It is a temperature regulated LMA. You put that LMA into the patient's mouth, and according to the temperature, it will just take the shape. Okay. Next is Slippa, which is streamliner of the pharynx. And last is Ambu Gain. Ambu Gain LMA. Okay. Right. Right. So this is regarding what, guys? This is regarding the laryngeal mask airway second generation. Third generation is we are having a new. This is the new one. This is called as Basca's mask, which is usually providing better when compared to the other LMAs. It provides a better seal for positive pressure ventilation. Okay. Then there is one more special type of LMA which is called as an intubating LMA. Intubating LMA means what? You can put this LMA and there is one small port beside this LMA. Through that port, you can intubate also. Okay, that is a special type of LMA. It does not come under the generation. So these are the generations of LMA. So remember, guys, with that case only, we are discussing all those things. Right? Sir, what about the first branch LMA? First branch LMA, classical LMA is also used. In elective cases, we are using classical LMA. But again, for elective cases also, if you are having an LMA that is preventing the risk of aspiration, that is second generation, go for second generation. Okay. Now, look over here. Apart from those, we also have to remember some adjuvant airway devices. The adjuvant airway devices on your screen, this is called as NPA, which is nasopharyngeal airway. Now, when do you use this device? Whenever a patient, imagine a patient is in a state of epilepsy or seizures, and you need to secure the airway. You need to give oxygen to the patient, but you are afraid that the tongue is in between. You are not able to place the Goodell's airway in that patient. So what you will do, you will put a nasopharyngeal airway to secure it, and you can ventilate the patient. Ventilate means you can push in oxygen. So remember, nasopharyngeal airway, before putting, check the size of it. Take the nasopharyngeal airway, keep between the tragus of ear and near the nair. If it is fitting there, then you can easily put that airway device. But it is having some contraindication. What contraindication, guys? Nasopharyngeal airway cannot be put if you are suspecting the patient is having base skull fracture. Base of the skull fracture. Don't go for it. Why? Because it can easily penetrate, it can easily go inside the brain also. So in those cases, or bleeding disorders, it is contraindicated. Okay. Now next airway device. Remember, guys, in this, when you place a nasopharyngeal airway, will it impact the gag reflex? No. Gag reflex, it has nothing to do with the gag reflex. If the patient is having gag reflex, such as in the case of Goodell's airway, some patients you want to place a Goodell's airway in order to give oxygen to the patient. If you are placing Goodell's airway, gag reflex can be seen. But with NPA, there is no gag reflex. Okay. Next is Goodell's airway. Now, guys, Goodell's airway. Goodell's airway is a oropharyngeal airway. Again, for Goodell's airway, take the airway, keep between the angle of mouth and tragus of ear. If it is fitting, you can easily put that airway. Okay? Exact sizes measured by keeping it between the angle of mouth and tragus of ear. If it is fitting, then you can put that airway. But again, gag reflex is seen with this. Okay, right. It's a oropharyngeal airway. Now, guys, coming to this. Now, just look over here. What is this? What is this thing? This is nothing but what? This is an epidural catheter. How do you say it's an epidural catheter? By looking at the needle, sir. So, with the needle, I can just make out what is this needle? This needle is having 1 centimeter of dark and light band, and it is an 18 gauge needle, which is called as two-Hoy's epidural needle. Once you are in the space, you place a catheter. Okay? And this is basically this is the epidural set. Okay, now guys, what is this picture? Can you say what is this picture? In this picture, there is a child in whom we are placing a needle at the level of sacral hiatus. So basically we are giving a sacral epidural, which is called as caudal block, or which is called as caudal anesthesia, normally used in children for anorectal surgeries. Okay, as the spinal cord is ending at the lower level in children, we go for caudal anesthesia just to avoid damage to the spinal cord. Okay, so that is this. Now, guys, look over here. Again, there is no such picture. They won't be giving such picture to you. What is this and all? This is a picture created by me so that you can remember something. This picture is related to the spinal anesthesia, guys. Come on, be fast and answer. This is basically a picture of emergency drug tray. Emergency drug tray. In emergency drug tray, guys, we will keep 4 drugs, 4 things. Okay. In the first column, as you see, what I have kept? Phenylephrine. Okay. This emergency drug tray can be used for any surgeries, but normally what I use is for spinal anesthesia, and also for general anesthesia, I'll keep this. Okay. But in spinal, why am I keeping this? Why am I keeping phenylephrine as the first? Why? Because remember, the most common complication of spinal anesthesia is what, guys? Most common complication is hypotension, which can be easily managed with phenylephrine. Okay. The second most common complication of spinal anesthesia is what, guys? Second most common complication is bradycardia. For that, you keep atropine. Okay. Next is you keep adrenaline. Again, remember, guys, adrenaline is not given in spinal anesthesia unless and until there is cardiac arrest. And you also keep laryngoscope, ET tube ready. Why? Because if the patient if the patient develops high spinal or total spinal anesthesia, then we can intubate the patient with the help of laryngoscope and ET tube. Okay. So remember, this is regarding the complications. Just brush up of the complications, guys. Okay. Now, pethidine is also kept. It doesn't mean that pethidine is not kept. Pethidine is also kept for shivering management. Now look over here. What is the pictures depicting? Now in this picture, there is a picture of what? There is a picture of scalene anterior and scalene medius. In between scalene anterior and medius, what is the plexus coming? That is called as brachial plexus. If you want to block the brachial plexus, it can be blocked in 3 approaches or 3 ways. What are the 3 ways? First approach is called as interscalene approach. Interscalene approach of brachial plexus. So in interscalene approach, when you are when you are blocking the roots, only the proximal roots C5, C6, C7 is blocked. So hence it is best used for shoulder analgesia. And nerve that is paired in interscalene, remember interscalene, the nerve is paired is ulnar nerve. Interscalene, I and U. Always I used to remember I and U are not always together. I and U are not always together. The nerve is paired is ulnar nerve. Okay. Next, second root is called as supraclavicular root. By far the most commonly used approach for brachial plexus is supraclavicular. Now, while trying to find the brachial plexus through the supraclavicular root, you might cause a complication. What complication? It is called as pneumothorax. But remember, the most common complication of supraclavicular approach is you might damage a nerve which is called as phrenic nerve. That is the most common complication. But the most severe complication is what? It is pneumothorax. Pneumothorax. Third approach of brachial plexus block is axillary approach. Axillary means you are introducing the needle through the axilla to find the brachial plexus and to block it. It is used for distal for distal hand surgery or palm surgery, you can use. The nerve that is being spayed in axillary approach is musculocutaneous nerve. Musculocutaneous nerve. Apart from that, guys, these three pictures were depicting those nerve blocks. What is this picture depicting? In the neck, he's showing some nerve is being blocked. He's talking about what? He's talking about stellate ganglion block. Stellate ganglion block. Now, guys, remember, stellate ganglion is blocked in what condition? Stellate ganglion is blocked if the patient is having some upper limb ischemia or some catheter-induced or drug-induced ischemia, or for PTSD, in order to reduce the sympathetic tone, you go for stellate ganglion block. Now, guys, in stellate ganglion block, they might ask you what is the landmark. The landmark is Chazakne's tubercle. Chazakne's tubercle is the landmark for stellate ganglion, and once you block the stellate ganglion, you will see what patient will have. Horner's syndrome. Patient will have Gutman sign. Come on, guys. Gutman sign is nothing but vasodilation of the nasal mucosa. Patient might have Muller sign, which is vasodilation of the tympanic membrane. Okay, guys. Supraclavicular block is used for almost all surgeries of the upper limb. Okay. Now, guys, coming to the general anesthesia. In general anesthesia, we'll start with the IV induction agents. Come on, guys. Just beef very fast. Look over here. The IV induction agent that we are discussing is, there are 4 IV induction agents: thiopentone, ketamine, ethomidate, propofol. Thiopentone, it's a yellow amorphous powder and it is regarded as an ultra short acting barbiturate. Why ultra short acting? Why? Because it is having rapid redistribution. Now, regarding these drugs, only you have to remember what are the effects on the systems. Remember, guys, thiopentone, when systems are talked about, system comes like CNS, respiratory, cardiovascular, and muscle. Thiopentone is the best friend of CNS and enemy of others. When I am telling best friend, remember thiopentone will be used as a drug of choice or induction agent of choice for pathologies of that system. What system? So CNS. What are the pathologies? In case of raised intracranial pressure, use thiopentone. Raised intracranial pressure, you can use thiopentone. In case of epilepsy, use thiopentone. In case of narcoanalysis, use thiopentone. Okay. Now it is an enemy of all other systems. All other means what? It is contraindicated. Contraindicated in asthma, contraindicated in shock, contraindicated in ischemic heart disease, right? And it is having no effect on muscle. That is the sodium thiopentone that we need to remember, right? Now, when we are discussing this IV induction sodium thiopentone, always remember, guys, 4 IV induction agents are there. All IV induction agents act through GABA except ketamine that acts through the NMDA. Next is ketamine. When we are discussing thiopentone, ketamine should be read simultaneously. Why? Because ketamine is opposite of thiopentone. Ketamine acts on the NMDA receptor, and when compared to the system, ketamine is opposite of thiopentone. Means what? It is the worst enemy of CNS. When I am telling it is a worst enemy, what does it mean? It will have contraindications. What contraindications, guys? CNS pathologies don't give ketamine. Raised ICP don't give ketamine. Epilepsy don't give ketamine. Hallucination don't give ketamine. Ketamine will worsen it. Okay. Next, for lungs, what we need to remember, it is a best friend. Best friend for all other systems. Yani ke it is best for asthma. It is best IV induction agent for asthma. It is best IV induction agent for shock as well as cyanotic heart disease. But again, contraindicated in ischemic heart disease. Why? Because it increases the heart rate and all. Workload of the heart will be still increased. Okay? And muscles, it will increase the muscle tone. Next is ethomidate. Guys, remember ethomidate, only one thing you have to remember. Ethomidate is the only IV induction agent used in ischemic heart disease. Why? Because it does not increase the heart rate. Only IV induction agent used in ischemic heart disease. Okay. Right. This is regarding this. Okay. Next coming to what? Next coming to propofol. Now propofol, by looking at the picture, it's a milky white solution. Milky white solution made up of egg, lecithin, and soy. Now, the main thing of propofol is an IV induction agent for day care surgery. when I am telling daycare surgery, with daycare surgery, you have to remember all the MCQs of propofol. When a patient comes for daycare surgery, what I will do, I will put an LMA. I'll avoid endotracheal tube so that the patient does not have sore throat. Okay. Apart from that, I will try to avoid the inhalational agents and I will give IV agents only to maintain the patient. Why? Because they are excreted very easily. So remember guys, for daycare surgery, I will put an LMA. I will go for TIVA. What is TIVA? Total intravenous anesthesia. Anesthesia given without inhalational agent is called as TIVA, right? Propofol has anti-emetic property. Propofol has anti-pruritic property. Anti-pruritic Antipruritic property is there with propofol, right? Apart from that, propofol is free from the side effects like malignant hyperthermia, and it can be safely given in liver disorders, and also it does not cause acute intermittent porphyria. Yani ki basically a patient of daycare surgery, when he's coming, I can give propofol. If you remember this, all the MCQs of propofol can be covered. Why? Because propofol is not only the IV induction agent of choice for daycare surgery, for all these conditions, it is the IV induction agent of choice. Okay. So this is regarding propofol. Now guys, look over here. What is done in this picture? Now in this picture, what is done? Someone is putting pressure on the cartilage so that the esophagus gets closed. This is called as Selleck's maneuver. Selleck's maneuver. Selleck's maneuver is done in what patients? In patients who are at high risk of aspiration. Who are the patients who are at high risk of aspiration? Obese patient, pregnant ladies, GERD, road traffic accidents, all these patients. Remember guys, these three patients will have one thing in common. All will have a raised intra-abdominal pressure. That's why they are at risk of aspiration. In patients who are at risk of aspiration, you go for RSI, which is called as rapid sequence induction, where you go for Selleck's maneuver. When are you placing the Selleck's maneuver? Immediately after induction. Placement of Selleck's maneuver is done immediately after induction. When do you remove this? When do you remove the Selleck's maneuver? That is also very important. Removal of this is done after intubation and inflation of the cuff. After inflation of the cuff. Inflation of endotracheal tube cuff. Okay. That's regarding what? That's regarding the Selleck's maneuver. Okay, guys. Now, look over here. Guys, is it clear? Come on, just give me a thumbs up. We'll try to finish it as soon as possible in most probably like 20-30 minutes we can be done. Okay, just look over here. Right. In this picture, what do you see? This is the picture depicting the action of muscle relaxant. Muscle relaxant, when you give, what muscle relaxant are we talking about? The non-depolarizing muscle relaxant. When you give a non-depolarizing muscle relaxant, what will it do? It goes towards the muscle. Okay? It goes towards this junction, guys. What is this junction? This junction is called as NMJ, neuromuscular junction. At the neuromuscular junction, it blocks the NM or the acetylcholine receptors by a mechanism called as competitive antagonism. All non-depolarizing are blocking by this mechanism. Whereas choline, there is no competitive mechanism with choline. Choline, when you give to the patient, it will cause depolarization, it will cause hyperpolarization, and then depolarization is gone. The mechanism of choline is different. Okay? Now, next, guys, anesthesia equipments. In anesthesia equipments, guys, what we need to remember? We need to remember the IV cannulas. Now, remember IV cannulas, they are 14 to 26 gauge, guys. For remembering this, you have to remember just a mnemonic, guys. The mnemonic is, oh, great God, please bless your people. Oh, great God, please bless, please bless your people. Sorry. So what does it mean? O means what? It is orange. Orange. Remember, guys, what is the flow rate in orange? If you want to remember the flow rates of the IV cannula, remember purple is the 26 gauge IV cannula, and the flow rate of purple, you have to remember like this. Flow rate of purple is 10 ml. Okay? And flow rate of 24 gauze is what, guys? It is 20 ml. Flow rate of 22 gauze is 30 ml. 20 gauze is 50 ml. And 18 gauze is 100 ml, 16 gauze is 200, and 14 gauze is 270 ml. The largest bore size is 14 gauze, 270 ml, commonly used in shock, whereas in pediatric cases, commonly uses yellow cannula, guys. Pediatric cases. Okay? In newborns or patients who are like low birth weight, you can use this 26 gauze. Okay, this is regarding what, guys? IV cannula. Now next is anesthesia machine. Anesthesia machine is a machine between the, it is an interface between the patient as well as the cylinders. Why? Because cylinders will have a high pressure. You cannot give that pressure to the patient. Machine will reduce the pressure and give to the patient. Now in this machine, what you need to remember. Now I have labeled some parts of the machine, guys. What are the parts? This part is called as vaporizer. This part over here is called as oxygen flush. Come on. Oxygen flush will deliver how much of oxygen? 35 to 75 liters per minute of oxygen. What is this part which is being labeled over here? The part that is being labeled over here is breathing circuit. And this is the flow meter. Okay. Now discussing about the machine, just look over here, guys. In machine, you are having cylinders. Cylinders are having different colors. All cylinders are given different colors. Cylinders fit to the machine with the help of an assembly called as yoke coil assembly. Inside that, there is a system called as pin index system that prevents wrong attachment of the cylinder. Now, that pin index system is different for different gases. For air, it is 1 and 5. For oxygen, it is 2 and 5. For nitrous, it is 3 and 5. And for Antonox, it is 7. Again, in the LRR, I have explained you what is a pin index system, how to remember it. Okay. Now, apart from that, guys, this picture over here is of what? DISS. DISS is what? Diameter Index Safety System. Directly, these pipelines are fitted into the hospital, into the hospital unit. And basically, the if at all the cylinder doesn't work, the gases can be provided from the hospital plant itself. So this is diameter index safety system that prevents the wrong attachment of the pipelines to this. Okay. Now they are given different color codings, but remembering the color coding, you have to remember the color coding of the cylinders, then you can remember the color coding of the pipeline. So look over here, guys. Oxygen, what is the color? Again, oxygen color is what? It is black body, white shoulder. Air is opposite of oxygen, that is white body, black shoulder. Okay, nitrous is complete blue. Nitrous, Neela, blue. Antonox is a mixture of nitrous and oxygen. That means what? It is having blue body, white shoulders. Blue body, white shoulders. Antonox is mixture of nitrous and oxygen. Carbon dioxide is gray in color. Helium is brown in color. There are many cylinders. Okay. So now look over here, guys. The pipeline colors also depends upon the cylinder color, but pipeline colors are taken from the shoulder color of the cylinder, guys. Look over here. Oxygen pipeline color is what? Just take the shoulder color. It will be white in color. Air pipeline is black in color. Nitrous pipeline is blue in color. And vacuum is used for suction and all. Suction pipeline is yellow in color. Vacuum, we add a stroke, it will become yellow in color. Okay, that's regarding what, guys? That's regarding the cylinder. Okay, right. Now just look over here, guys. This thing, sevoflurane. Uh, First of all, this devices over here is what? This is called as vaporizer. Vaporizer function is to store the liquid inhalational agent in it. Now in this, we have to remember two inhalational agents. Okay, two inhalational agents in detail, which is sevoflurane. Sevoflurane, for that you have to remember a mnemonic which is called as smart kit. Okay, smart kit. What is smart kit means, guys? Sevoflurane is sweet odor. Sevoflurane is sweet odor, right? And it is yellow in color. Come on. M stands for what? M stands for what, anyone? A stands for it is used for bronchial asthma. R stands for it is rapid acting. Rapid acting, why? Because it's having a low blood gas coefficient. Come on. M stands for what? No, no myocardial. Okay. So sevoflurane, why it is happening? Okay. Now you need to remember sevoflurane, it is having sweet odor. It is used in bronchial asthma, rapidly acting, right? Yes. It is having myocardial means what? Having minimal myocardial effect, minimal effect on the myocardium. Minimal effect on myocardium. Guys, sorry. Today, very much disturbances. Right? T actually it comes with R only, guys. Okay. And if you want to remember T, you can remember it is toxic for the renal, guys. Renal means what? If at all sevoflurane, if you give in low flows, it will form a compound called as compound A, which is nephrotoxic. Compound A, which is nephrotoxic. Okay. So this is regarding the sevoflurane. Sevoflurane can be used for induction as well as maintenance purpose. Now, next is what? Halothane, you have to remember. 4 heads of halothane. We have already discussed in the LRR. I won't be discussing, just you go through the LRR, you will come to know. Okay. Now, there are few things that we need to just discuss. Diffusion hypoxia, which I feel that it might be asked. Take a diffusion hypoxia, even though it does not have any picture. Diffusion hypoxia, do you know what is diffusion hypoxia? At the end of surgery, nitrous is occupying much space in the alveoli, displacing the oxygen. That's why patient becomes hypoxic. In order to prevent this, what we give? We give oxygen during the recovery period. How much of oxygen? 100% of oxygen for 10 minutes during the recovery period to prevent this diffusion hypoxia. Okay. You also need to remember something about MAC. Guys, what is MAC? Minimal alveolar concentration. What does MAC indicate? The potency of inhalational agent. Low MAC means what? Low MAC means high potent, and high MAC means what? Low potent. Low potent. Okay. That's regarding the MAC value. Next is apneic oxygen. You know, guys, when is apneic oxygen given? When do you give apneic oxygen? Apneic oxygen is given when the patient is not breathing. Yani during anesthesia, during the muscle relaxant effect, when the patient is not breathing, you give oxygen to the patient. That is called as apneic oxygen. Giving pre-oxygenation when the patient is already breathing. If you give pre-oxygenation, that is not apneic oxygen. Okay. Next. Next, guys, regarding the breathing circuit. Now, everyone look over here. Regarding the breathing circuit, they are semi-open and they are open, semi-open, and they are closed breathing circuit. We are discussing about the semi-open breathing circuit, which is called as Mapleson circuit. In that, you are having A till F. Now, guys, remember, if you want to remember through the picture, you have to remember through the APL valve. Just look over here, APL valve. This valve over here is the APL valve. Now, if the APL valve is near to the patient end, that is A, B, and C circuit. If the APL valve is away from the patient, it is called as D circuit. Valveless and bagless circuit, it is E. And only valveless circuit, it is F circuit. So anyways, guys, APL valve near the patient, A, B, and C. B and C are not used. We are concerned with A, D, E, and F. A is the circuit of choice for what ventilation? Spontaneous ventilation. It is also called as what circuit? McGill circuit. Okay. Now coming to Mapleson D circuit. Mapleson D circuit, the APL valve is away from the patient. When the APL valve is away from the patient, it is Mapleson D circuit, also called as Bain circuit. Also called as what circuit, guys? Bain circuit. And this is a circuit of choice for what ventilation? This is a circuit of choice for controlled ventilation. Again, I have explained in the LRR about this circuit. Okay. Then is Mapleson A, which is a bagless and a valveless circuit, also called as ISTPs. ISTPs. Okay. ISTPs. And last is Mapleson F circuit. Mapleson F circuit is the circuit of choice for what ventilation? It is a circuit of choice for pediatric patient. Pediatric patient. Okay. Whether it is controlled or spontaneous, you use this Mapleson F circuit. Okay. Now coming to the next breathing circuit, which is called as closed circuit. When do you call it as a closed circuit? When there is no APL valve. All the gases exhaled from the patient will enter this pipeline, and through this it will enter this chamber which will absorb the carbon dioxide. What is this chamber called as, guys? This chamber is called as soda lime chamber. Basically it is a carbon dioxide absorbing material, soda lime or bara lime, guys. What is it made up of? Now this soda lime is made up of 80% of it is calcium hydroxide, which is a major component, 16% water, 3% it is sodium hydroxide, which is the main component without which it cannot be formed, and 1 to 2% it is made up of potassium hydroxide and silica. Silica is added to just improve the hardness of the soda lime granules. Okay. Now guys, coming to this question. A patient came to the casualty with the complaints of shortness of breath and a saturation of 88%. This device was used for oxygen administration. How many liters of oxygen can be given through this device and what FiO2 can be achieved? Come on, guys. Come on, please answer this. What is this device? First of all, when a patient always comes with a saturation, remember, with this we can come to know that the patient oxygen saturation is 88%. His respiratory pattern is still stable only. When the respiratory pattern is stable, patient is not having much of desaturation, we can go for a low flow oxygen device, and which is the first low flow oxygen device that we use. It is called as nasal cannula. When you give nasal cannula, how many liters of oxygen can be delivered? 1 to 6 liters. That will deliver an FiO2 of 25 to 45% with nasal cannula. Remember, if he's still not improving, then we'll go for what? Then we'll go for the other device, which is called as what? Face mask. Okay? Face mask. It will deliver how much oxygen, guys? It will deliver 6 to 10 liters of oxygen, and which will deliver an intern and FiO2 of how much? 35 to 65%. If still not improving, then you can go for what? NRBM, non-rebreathing mask, which will deliver of oxygen of flow of in this NRBM is how much, guys? It is 10 to 15 liters, which will deliver an FiO2 of 65 to 95%. Again, these are what, guys? Low flow devices. If the patient is not improving, then you can go for a high flow fixed performance. High flow fixed performance device is basically the HFNC and Venturi mask. Venturi mask is a variable performance also. So look over here, guys. This is Venturi mask. Now, Venturi mask can deliver how much? Venturi mask can deliver 2 to 15 liters of oxygen that will provide an FiO2 of 25 to 24 to 60%. With HFNC, the flow of oxygen is how much, guys? The flow of oxygen is 40 to 60 liters that will provide 100% of FiO2. Okay, guys. Now, look over here. These are all what? These are all low flow devices. Now, guys, Venturi mask. Just look over here. Venturi mask. When you see the Venturi mask, there are different colors of it. Now, don't get confused, sir. Agar Venturi mask, they have been asking how to remember the colors. For that, there is a mnemonic, guys. There is a mnemonic called as boy was often yelling, run girl. For a Venturi mask, you have to remember. Remember, Venturi mask works on a principle which is called as Bernoulli's principle. Okay. Now, why am I telling boy was often yelling run girl? Boy stands for blue, was stands for white, O stands for orange, Y stands for yellow, R stands for red, and G stands for girl. Now, you have to remember this thing. When it is a blue Venturi mask, always it will be a 2 liter. The flow rate is 2. And as soon as we are going down, the flow rate increases by 2 liters. White 4 liters, orange 6 liters, yellow 8 liters, red 10 liters, and last green you have to add more 5 liters over here. It is 15 liters. That is the flow rate. And how much of FiO2 are we achieving, guys? With blue Venturi mask, we will achieve an FiO2 of 24%. After that, just you add 4%. That is with white 28%, with orange 31 to 32%, with yellow it is 35, with red 40, and with green it is 60% of FiO2 we are achieving. This is regarding what, guys? This is regarding the Venturi mask. Okay. Next is AMBU, guys. AMBU. AMBU full form is what? Artificial manual breathing unit. Right? Artificial manual breathing unit, which will provide a patient with 100% of oxygen. Right? In this AMBU, they are having it is having two valves. One is called as the Rubens valve. Rubens valve, which is a unidirectional valve. which try to prevent the rebreathing. Second is called as a pressure releasing valve. Pressure relieving valve. The pressure relieving valve. The pressure relieving valve, the pressure is relieved at 30 to 40 centimeters of water, guys. Okay. This is regarding the AMBO. Next, look over here, guys. This picture, what does this picture depict? This picture depicts, yani this is basically the recovery position that we give to the patient. When do you give to the patient? When a patient has collapsed, when you go near the patient, when you look for the pulse is present. Okay? When the patient is having pulse is present and breathing is also present. Yani pulse is present and breathing is present. That means it is the patient does not require any CPR. You just lie the patient to a lateral position. That is called as recovery position when pulse and breathing is present. Okay. If the pulse and breathing is not present, then you have to make the patient in supine position. You go for CPR with ACLS protocol. Guys, now look over here. In ACLS, there are two rhythms. What are these two rhythms which I am showing you over here? This rhythm is ventricular tachycardia and this is called as ventricular fibrillation. These two rhythms are the shockable rhythms of the heart, VT and VF. Now guys, while giving compression, what is the rate of compression that we need to give? In a minute, how much compression, guys? In a minute, you need to give 100 to 120 compressions. In a minute, you need to give 100 to 120 compressions, right? And what is the ratio of compression that you need to go for? It is 30:2. Yani 4 sets of 30:2. In the LRR, by mistakenly, I have told 30:1. It was just with the flow of words, it is 30:2 only, guys. Okay. So ratio of compression is 30:2. 4 sets of 30:2 you have to give. Whether you are a single rescuer or more than one rescuer, in adults 30:2. In pediatrics, if you are a single rescuer, 30:2. If you are more than one rescuer, you can go for 15:2. Okay. Right, guys. Next. Look over here. Chain of survival. This was the old chain of survival and this is the new one, guys. This is the new one. In new and old, what has been added over here, guys? In old chain of survival, when you compare with the new one, only the component that is being added is recovery. Yani ke activation of emergency response system, high quality. Remember, the heart of ACLS is high quality compression. Next, defibrillation, advanced resuscitation, post cardiac arrest care and recovery. Okay. Next, guys. Monitoring in anesthesia. When we are discussing something about monitoring in anesthesia, there are many things that you monitor. I'm not talking about the general monitoring. I'm just talking about these two things which I have been given over here. In general monitoring, you monitor for the patient's saturation, monitor for the patient's pulse and all. Now look over here. The first picture that is being given over here is what, guys? It is train of 4 monitoring. That is basically used for neuromuscular effect monitoring. Train of 4 monitoring, you give 4 twitches and you basically measure the twitch height and you take a ratio, divide the T4, the fourth twitch with the first twitch. Okay? Train of 4 ratio in case of depolarizing muscle relaxant is train of 4 ratio in case of depolarizing muscle relaxant is 1. What does it mean, guys? Train of 4 ratio in case of depolarizing muscle relaxant, it is 1 means what? Yani ke basically remember in depolarizing muscle relaxant, when you give to the patient and when you look at the twitch height, it will be equally reduced. T4 to T1 is T4 by T1 is 1. Whereas in case of non-depolarizing muscle relaxant, guys, what will happen? You will see the 4 twitches very much reduced or 4 twitches gone. Then the third twitch is more than the fourth twitch. Second is more than the third twitch. Yani ke it is decreasing like this. So when you take a T4 to T1 ratio in case of non-depolarizing, for a good block, the ratio should be less than 0.4 or sometimes 0 also. In case the fourth twitch is gone, it is 0. So in non-depolarizing 0, in depolarizing it is 1. Again, train of 4 also have explained in the LRR. Okay. Next, guys, what is this shown over here? This yani ke you are able to see that on the patient's forehead, we have applied something and we are monitoring something. That is nothing but BIS. BIS is nothing but bispectral index, which monitors what? Which monitors the sum of EEGs. Okay, this is used for monitoring what? This is used for monitoring the awareness. Is the patient aware or not during anesthesia? Okay. Guys, what is this thing which is being shown over here? Something I have introduced into the patient's esophagus and then taking picture of the heart or scanning the heart. Come on, guys. What is this? What is this thing? This is called as very good transesophageal echocardiography. Okay, it is an echo, but what you are doing through the esophagus. So it is a transesophageal echocardiography commonly used for detecting VAE. VAE is nothing but venous air embolism. Okay, venous air embolism. The murmur that you see in venous air embolism is Mill-Wheel murmur, right? Next, guys. Over here in this picture, what do you see? A tourniquet is being tied and someone is giving drug to the patient. When a tourniquet is being tied and drug is given on the same hand, that means he doesn't want the drug to go up. In which condition you will give this drug on the same hand and tourniquet in the same hand? When you are going for IVRA, for upper limb surgeries or lower limb surgeries, you go for IVRA, where you are blocking the pathway of local anesthetic so that it does not go and mix with the systemic circulation. So in IVRA, it is also called as Bayer's block. In IVRA or Bayer's block, what is the pressure of tourniquet in upper limb? The pressure of tourniquet in upper limb in Bayer's block or IVRA is how much, guys? It is 50 plus systolic BP to occlude the supply. Okay? Whereas in lower limb, what is the pressure? It is 100 plus systolic BP. 100 plus systolic BP. Why? Because lower limb requires much pressure, much muscle mass is there. Next is EMLA, guys. EMLA is what? Eutectic mixture of local anesthetic commonly used as a surface anesthesia in children. In children, you use this EMLA cream like if you want to put a tourniquet, you can use this EMLA cream. What does EMLA consist of? 2.5% lignocaine and 2.5% prilocaine in equal concentration. Now look over here, guys. When you are applying EMLA, sorry, when you are applying EMLA, you need to take care of one thing. It should never be applied in neonates. Why, sir? Why never be applied in neonates? Why? Because if you apply EMLA in neonates, neonatal skin can easily absorb the prilocaine, and which can lead to a condition called as methemoglobinemia. Hence, EMLA is contraindicated in neonates due to the risk of methemoglobinemia. Okay, guys. So these were the few photos, few pictures. Initially in the start, there was some disturbance and in between some disturbance. Is it clear, guys? Is it clear? Guys, if you are asking, is this enough? I would never suggest it's enough. Always remember, if at all you want to study and you don't have time, and if you want to study anesthesia now, at least combine LRR with MCQ based, image based discussion that we have done today. Okay. Is it clear? Any doubts, guys? Most of you had doubt in that thing, that tube, combi tube. Combi tube is simple, guys. Place the combi tube, either it can go into the trachea or the esophagus. Trachea mein, if it is going, just ventilate through the tracheal port. There are two openings. No, one is the tracheal, one is the esophageal. Ventilate through the tracheal port. If it goes into the esophagus, block the esophageal port and ventilate through the other port. Where should you palpate the ICA? What is ICA? Mapleson circuit, once again, okay. Mapleson circuit, guys, remember in Mapleson circuit, A to F is there. If at all you want to remember pictorially, always remember ABC circuits are in ABC circuits where the APL valve is close to the patient. Okay? D circuit, valve is away. So remember, valve close to the patient, ABC. Valve away from the patient, D circuit. Valveless and bagless circuit, it is E. A circuit which is only valveless with bag is circuit F. And in that only three circuits are important, three MCQs. Circuit of choice for spontaneous A. Okay? But remember a small thing just guys. For spontaneous and control, you can remember SACD. You can remember this small mnemonic, guys. Just look over here. SACD. SA stands for spontaneous A circuit and CD means controlled D circuit. SACD. Mapleson E circuit, IRS TPs, it is basically a trial circuit, guys. Commonly, when do you use is it? Like whenever the patient is being weaned off from the mechanical ventilator, we give a TPs trial. We just give the circuit and connect oxygen to the patient before removing the patient from the ventilator. Semi-close and close. Basically, if you are using a closed circuit, there are some advantages. Normally, we are using closed circuit. Advantages are there is no theater pollution. Wastage of gases are less. So commonly nowadays we are using closed circuit only. But if closed circuit fails, you go for semi-closed circuit. Okay, bhai. Chalo, anything. If at all you are having doubts, which can if you are not able to post it now, you can post me on my ID on the Instagram. Okay. Thank you, guys. Thank you. Important topics of anesthesia for NEET PG, FMGE. Go through the LRR. I have compiled the whole anesthesia in 3.5 hours. At least just go through it. Right. I cannot say that this can come, this will come. But go through the LRR. Have you gone through the LRR, guys? Just a small question. Have you gone through it? Yes. Those who have gone through it, for my personal feedback, how is it? What can anything should be done for improvement in it? How is it, guys? It is very effective. Okay. Okay. Okay, guys, I won't be wasting your time. Sergi, can we get the PPT of this class? Yes, you will get. Okay, guys. Okay. So all the very best, all the very best. We need to revise. Okay. Right. All the very best, guys. I'll be signing off now. Thank you.